I'm Sikander Ailawadhi. I'm a specialist in multiple myeloma, and I'm from Mayo Clinic in Jacksonville, Florida, and I lead the myeloma group at Mayo Clinic. Excellent question. So the IRAKLIA study, I should say, was not necessarily initially designed to answer this question of prior CD38 exposure, but to their, I would say, commending them on how the study was designed, it allowed patients to go into the study even if they had prior exposure to CD38 monoclonal antibody. Now, why is that important? In the US, especially in our treatment landscape, patients get exposed to an anti-CD38 monoclonal antibody generally in the first line of treatment or quite frequently in the second line. So by second line, almost everybody ends up getting exposed to one of the monoclonal antibodies against anti-CD38. And a lot of the clinical trial data that we see coming out of all these meetings talks about patients who are relapsed refractory but are naive to the antibodies, means have never seen that. So you can see there is a data gap where a lot of these large, new, novel trials are talking about anti-CD38 naive patients, when in the real world, we don't have that population existing because patients are exposed to anti-CD38. So what IRAKLIA did was, it allowed patients to get into the treatment even if they had prior anti-CD38 treatment, even if they were refractory to prior anti-CD38 treatment, as long as there was at least a 9-month gap from the last anti-CD38 treatment to when they got into the study. This gave us an opportunity to generate data on, in a way, retreatment with anti-CD38 monoclonal antibody-based treatment. So the prior anti-CD38 therapy was given to about 67 patients in the whole of this IRAKLIA trial, which means 67 patients had been previously exposed to an anti-CD38 antibody. So this data that was presented at ASCO that I presented is primarily focusing on those 67 patients and how they compare to the rest of the patients out of a total of about 560 that the study included. So what this study showed, what this data analysis showed, was that the patients, of course, we know that those who have been exposed to CD38 before, their outcomes overall are a bit inferior, lesser response rate, lesser progression-free survival, shorter duration of response. But importantly, if the patients were previously exposed or even previously refractory, meaning frankly resistant disease to the anti-CD38, the outcomes were very similar between those. So now looking at only the CD38 exposed group, whether the CD38 exposed was just exposed or exposed and refractory, this subset analysis showed that their outcomes were similar when they were treated with Isatuximab, Pomalidomide, and Dexamethasone, or Isa-POMD combination. The other important finding that was shown was that if there is a longer duration of washout from the previous anti-CD38 administration, then the patients are more likely to do better, as against if there is a shorter washout period. Now, the study required a 9-month washout, but when the data was analyzed for all the patients, these 67 previously exposed patients, the median washout was about 20 months. And in fact, those patients who were re-exposed to the CD38 at that median 20 months or longer, their outcomes were identical to the patients who had never been previously exposed to CD38. So, just to summarize again these 2 points, number one, whether the patient had previous exposure or exposure with refractoriness to CD38, as long as there was sufficient washout, at least a 9-month washout, the outcomes of those 2 groups were similar. And if the patients had more than 20 months of washout, then the outcomes were similar to as if the patient had never had a CD38 monoclonal antibody before. So from a safety standpoint, what we clearly found was that there was no different safety signal, irrespective of whether the patient was CD38 previously exposed or not. So that was very reassuring, because there would always be a concern that if a patient is previously CD38 treated, well, maybe they'll have more side effects or something because they had a little bit more heavily pretreated myeloma. But it was clearly seen that it was not a different side effect profile, so the prior CD38 exposure did not change the side effect profile of Isatuximab in the IRAKLIA trial. So I think the on-body injector, the way I look at it, is a huge step forward in how we consider treatment for our cancer patients. This would be the first time ever that a cancer therapeutic drug will be administered in this very patient-friendly and patient-centric manner of the on-body injector, where the patient has this disc which is loaded with the drug. It is pasted on, or they just take off a sticker and put it on their abdomen, on their skin, and a button is pressed. Then over the next several minutes, the drug is very gently injected into the patient. And once the injection is done, that device is peeled off and thrown away. So that's a very patient-friendly manner. And what IRAKLIA and some other trials like ASCO have shown us is that patients overwhelmingly preferred that matter, even compared to a manual subcutaneous injection push. It was more patient-friendly. That device worked in 99% plus cases out of hundreds of administrations. That was also a preferred method by healthcare providers, so nursing staff, doctors, everybody preferred. In fact, one of the trials that was done with the subcutaneous device showed that if the patients were treated first with the other method and then with the on-body injector or vice versa, at the end of it, majority of the patients, about 3/4 of the patients, said that they would prefer their treatment with the on-body injector because of the way that device is. So I am very excited about it, and I'm hoping this will come out in the near future and patients can start deriving benefit from it. I think there are some other very important aspects of how this data could be very impactful in the real world. In today's day and age, we are constantly looking for options for our patients, sometimes to clearly provide them with deep responses, at other times with just to get the patient tied over to potentially some other treatment in the future. In the current myeloma landscape, where daratumumab or Isatuximab based exposure is happening very frequently in the first or second line, I think knowing how to retreat with these agents, with Isatuximab specifically in this study, that fills a very big data gap. We have been using CD38 monoclonal antibodies for years, but we never knew how to retreat with these agents. So you can imagine this kind of an approach could easily be used if a patient had, say, a CD38 based treatment in the past, then they went to something else, could be one of the novel drugs, these T-cell engagers or CAR-T or something. And then potentially, subsequently, as long as there was a sufficient gap, the patient could come back to treatment with a CD38-based regimen. That, I think, is a tremendous opportunity and understanding we have gained, which will impact patient care everywhere.